Good. So these are the investigators on the Virtus trial, and the determinants of venous outcome. You've heard that this morning. Etiology obviously has something to do, quality of inflow, outflow, and optimized anticoagulation. What we don't know is the degree of stenosis or obstruction, lesion, stent location, and the length of the stent, and impact of the vessel stent morphology on the outcome of these patients. For example, if you look at these two, they're both post-stented. And if we look at the ratio of A to B, which is called the aspect score, does it make a difference if you get this kind of morphology after stenting, or as opposed to this kind of morphology? You've seen the Vici stent characteristics already. I won't get into it. And the Virtus trial, I'm going to discuss about the pivotal study. This was by design broken down into feasibility and pivotal for a total of 200 patients. It's important that this is the only study so far, probably likely in the future, that has venography, duplex ultrasound, and IVUS at baseline and at follow-up. So this is a great correlative study to, in fact, see what is the gold standard in these patients in terms of imaging. This is the patient characteristics. You've seen it, and it's important to notice, and Dr. Sterling mentioned that already, that 3/4 of these patients were post-thrombotic by design. In fact, FDA required that at the time of the enrollment of this study. It's not that we sort of decided that's what we were going to do. This is how the breakout turned out in these patients. Suprainguinal 62%, infrainguinal, as you can see. The important thing is about 38% of the patients, the stent extended below the inguinal ligament into the common femoral, and about 32% involved the entire length of the common femoral through the common iliac vein. So this is a pretty challenging group, and this is the type of patients that we included. 75% post-thrombotic, and 41% were complete occlusion, such as this. So pretty challenging group. So let's see what the data looks like. You've seen this primary patency. Now I submit to you, when you see the primary patency of venous stent in these trials, it's a completely meaningless number. What you need to look at is the difference in outcome of different subgroups. In this case, the post-thrombotic and non-thrombotics, there were no acutes. You saw this curve before, and you can see there are 3 different diseases we're treating here with 3 different outcomes and prognoses. So when you look at these outcomes in these patients, they need to be identified as to what the patient population is and what it looked like. These are the, in terms of the venogram per diameter of stenosis, lumen area, and the aspect ratio. Now, why is this aspect ratio is important? Because this turns out to be a huge determinant of clinical outcome, not patency, but clinical outcome in these patients. And if you look at the clinical improvement, there was significant improvement in the clinical outcome across all patients, and we looked at multiple variables. These are the variables that actually stood out. The greater increase in cross-sectional area post-stenting, that's logical and intuitive. Greater post-stent decrease in aspect ratio. So now this is where that morphology comes in. So the rounder the vessel looked, the better the clinical outcome was. I'm not talking about patency. The correlations of venous patency is actually a paper coming out shortly, but this is. And also stent location. The stents that extended into the common femoral vein below the inguinal ligament, those patients actually did worse. And the reason probably for that is that those patients generally are the patients who have more extensive disease, some of which we saw today. So in conclusion, Virtus included many patients, challenging, all sorts, chronic and non-thrombotic. And the lesson is that morphology and lumen quality is important in the clinical outcome, and so does stent location and stent length. Thank you very much.